So we're gonna go ahead and get started. This QR is just a request for what you'd like to see in our spring meetings, any speakers or any like certain career paths you'd like to hear from. You can scan that QR code and fill it out. I'll leave it up for a second. Yeah. Um, is it? Yeah, we'll send in the group meet. Thank you. And then just a mental health reminder for the week. Tough times never last, but tough people do. If you're struggling with anything, she's not here tonight, but please reach out to our mental health chair, Addison. Her contact info is in the group me. And then
And just a reminder to everyone that PVMA is hosting our Fall Essential Needs Drive for the month of November. Feel free to drop off any items at a club meeting or contact me. I'm more than happy to organize a pickup time with you. You get one additional point for participating. If you guys are interested in running for e-board in the spring, you need 3 additional points to be considered an active member, along with paying dues and attending 2 EP meetings. So this is a really quick and easy way to get a point. There's also an event called Battle Against Hunger. You guys maybe received an email from Student Life earlier this week about it, but it's essentially exactly what we're doing. So all of the donations, food donations we get are going to go towards this, and it's actually a student organization competition. We cannot let Engineers Without Borders win again, so make sure to donate. And then an issue that was brought to our attention from some of our members here on campus that are lacking transportation, or that you guys are struggling to find transportation to some really cool off-campus opportunities. So if you're interested in joining this carpooling spreadsheet, essentially we'll have students in this organization sign up to offer rides to members to different opportunities off campus. If you volunteer to be one of those people that is offering a carpool, you will get an additional points, another quick and easy way to do that. Due to safety reasons, I won't be publishing this on the website. It's going to be password protected and you'll need to see me in order to gain access to it. But if you are interested, feel free to contact me. I'm more than happy to help out. You just need to authorize that you're a student.
Mm. All right, today we're going to be hearing about from Dr. Motta about small animal surgery. So I'll go ahead and hand it off.
Thank you, everyone. Thank you guys for the invitation. And that actually allowed me to see that beautiful moon. Did you guys see the moon tonight? So cool. Typically, I wouldn't even see it. Those are my 2 dogs. The little one is Nutella. The bigger one is Malu. Malu is a border collie. Do not get a border collie unless it had lots and lots of energy to play with them, because she totally is like 200 times tennis ball every single day. And that's not enough for her. Little one is a mix, a poodle mix, Australian Labradoodle. She do whatever you want her to do. She's actually one of our dogs that we use for classes in the vet school. And we do OSCEs, which are, can you guys hear me okay, even in the back? They are practical exams, and we have a professor watching and grading every single one of the students. The OSCEs happen every semester. She's one of our OSCE dogs too, so you guys learn how to do physical exams on her. And when it comes to do the practical, she will help you kind of like check my ears. How about my other ear? And eventually, if the student feel like they're done, she'll come and put their belly in front of them and like, do you want to palpate my abdomen here? So she's really not the best for making sure the student remember, because she'll remind them of what to do. Malu being the border collie she's not good teaching dog yet, because she's all over the place. She wants to do everything you want. If anybody feels like they're gonna start running, she's like, I'm gonna go get you. So she's not there all the time. Once you get in vet school, and I'm assuming everybody's wanting to go and get in vet school. Once that happens to you, you're gonna see lots and lots of me. I teach the canine anatomy. That's happening in the first semester, the first year. I also teach in the clinical skills. I'm a big part of the surgery training program, and we started training surgery on the first semester of the first year. So even when you're doing your dissection and anatomy, you could be practicing surgical skills in there. You could be holding your instruments appropriately, so you're not fatiguing your hands, you're not destroying your tendons for later in life. So we'll start, the clinical skills actually is the second lab that you have in vet school. You learn how to apply sutures, how to insert a blade into a blade handle, how to make incisions, and how to safely get rid of everything else and put stuff away. I also teach in clinical skills 2. We typically move on from simulators into more cadaver tissue. And then clinical skills 3, we get live animal surgeries, and every single vet student will do a spay or a neuter in a 3rd-year class. And that's what's happening right now. It started 4 weeks ago. Every Tuesday and every Thursday, we have 14 surgeries that are done by students with 3 supervisors. Myself as a surgeon, I have Dr. Carson as a second surgeon, and then we have one of the surgery residents that's there with us. And we go through the whole process with you guys. So every single person gets to cut an animal as a 3rd-year student. Then in the 4th year is a bunch of rotations. Every 2 weeks, you do a different rotation in a different department. And one of the rotations is small animal surgery. Those are typically referred animals that are coming in for a very specific disease, something that a regular vet hasn't been able to take care of. So usually our surgeons are cutting those, you get to watch. But there is a shelter rotation. That's a 2-week rotation where you stay in the Capital Humane, used to be Capital Area Humane Society, Columbus Humane. They are in a program with OSU, so we use all the surgical terminology and all the surgical techniques that you've been learning to that point to do all the spays and neuters. Shelters could be doing spays and neuters with minimal draping, with minimal anesthesia. That's not how we do it. We do it like you're doing for a patient in the hospital. We want to keep your infection rate to 2% or below. So everything asepsis is fully respected. No animal get antibiotics unless you break asepsis or you break sterility. But the whole process of going through surgery from pre-medication, catheter placement, induction, intubation, cut, suture, recover, you will be doing that all day long for 2 weeks. And typically every student going through that rotation will do about 30 surgeries. So by the time you get your diploma in your hand, you've done about 30 to 35 surgeries. Much higher than the average student graduating a vet school, way higher than any vet school I worked for. And I've worked for Colorado State and Cornell, and both those universities will get about 2 to 3 space per student. So if you ended up getting here at Ohio State, you get a lot more exposure to surgery than the average student, which if you talk to my 3rd-year students right now, the ones that have already cut, they'll be like, it's awesome. The ones that haven't cut yet, because we still have a month of this, will be like, it's horrible. It doesn't matter if you like surgery or not, you still have to cut. And that's what it is. You're getting a diploma that tells you can do surgery. So every single person will go through it. We're there to help, but the more you put in, the more you get out of it. It's a great milestone, but it's also very scary. Some people puke before, some people faint on the way of surgery, some people do great. So it's a matter of being prepared, and any opportunity you have to get more preparation, better. Other things that I do, so our surgery program is called SAOP, Small Animal Operative Practice. You hear that word a lot. We just talk about SAOP. It's one of our labs. It's our live surgery labs that happens twice a week for every semester as a 3rd year. And we could do some cadaver stuff in there, but mostly is that live animal procedures that we're doing. I love 3D printing. I am very, very interested in simulation for teaching. I know how much fear can destroy performance. So having simulators to get you to feel good about what you're doing and give you practice time is a big part of what I do. So not only I'm training you for surgery, but I'm also invested in figuring out ways that you can practice more without having the official bleeder in front of you, without having an animal under anesthesia. You can still do spays and neuters with simulators before you get to do your live surgery. So a lot of the simulation has to do with pouring silicone, mixing silicone, 3D printing parts. And now we're getting more and more into AI on the sense of using AI as feedback. I talk to the students as they're doing surgery. There's a lot of feedback on the go. But again, with the nerves and the stress, they don't necessarily remember everything we talked about. So having this recording and having this becoming a documentation that then becomes feedback form for them is my next goal right now, is that I can be in surgery, scrubbed in, I can't touch anything, but I can still be recording every conversation, and that becomes a documentation for the student to know their strengths and their opportunities to improve. Good so far? Anybody here has ever done any 3D printing? Anybody has messed up with silicone? If those things are interesting to you, Danielle over there, as a 7th grader, has a project where she was making canine bladders and they were doing silicone pouring. And then they work on making kidneys. They were doing 3D printing for a mold for kidneys. So that stuff she's been exposed to. She's pretty good at it. She's got good skills. Some of the stuff that students are learning the first year, they were learning as they were very little. So she's she's my daughter, always been my helpful thing in the sense of like, if they can learn this at age 6, you guys can learn at age 20. It can be done. It's hard. Some things are hard, but everybody can get to it. Any questions so far? All right. So today we're going to talk about Lily June. It's a fake name. It's a real dog. It's a real clinical case. Anything that had the animal name has been changed, so we don't have to sign any papers with you not sharing any information. This is a 6-year-old intact Chihuahua, female, and she comes in with lethargy, anorexia, and she's also a dipsic. She has a vaginal discharge for 9 days. Do we all know what lethargy is? Like what we feel right after lunch with a really boring lecture kind of thing, right? We as faculty try to get you to get out of lethargy right after a meal. Sometimes works, sometimes not. How about anorexia? And then a deep sick, not drinking. Says right there in the slide, right? So we really, really encourage people to use medical terminology as much as possible. This is what should be going medical records, and not necessarily not drinking, but we should have better medical terminology for those things. And a vaginal discharge for 9 days. What kind of questions do you want to ask the owner? And what do we want to do with Lily? This is just the information you got right before you enter the room. You have the records in your hand. Your technician got the history, gave it to you. You start elaborating some questions you're going to ask those owners. What does it come to mind? Yep. Last heat cycle, perfect question. We know she's intact. So how often do animals will enter a heat cycle? Canines. Every 6 months, perfect. So we want to know how far away that was, if it was 6 months ago, if she's starting to enter a heat cycle, maybe that's what the discharge is like, or if it was a little bit sooner than that. What other questions do you guys have? Go for it. What'd you say? I'm patient. Yep. What kind of urination she has, if they're actually able to see their urine. Sometimes they just let the dog out in the backyard and don't see what the urine looks like, but ideally we want to know what kind of urine. Is it bloody? Is it normal? Is she actually having any pain for urination? So you're probably thinking some sort of possible urinary infection, right? It's a good thinking process. Yep. If she's being going at it, if she's trying to lick that area, perfect, good question. And if she is that something you could tell by your physical exam that you, even if the owner didn't notice, would you be able to tell by examining? Yeah, usually the parts they're licking all the time will be more red and swollen. Great question. Yep.
If she started eating any new food,
If we have any changes in her diet or maybe a new food like that a lot. Yep.
who's been exposed to injectable.
Maybe a possibility of a male that bred her. So if any chances that she's being exposed, that's great. So we're probably thinking a potential pregnancy or even an infection from having exposure to a male. Great question. And then the other questions that you should always ask, this is going to be part of your life. Is she dewormed? What's her vaccination status? Is she on preventative for anything that you can think about, ectoparasites, endoparasites, and any change in the household? Is there a baby that was born, or maybe they moved to a new house, or now they got a cat, or any new puppy in there? So all the kind of questions that should go for everybody. So not necessarily only specific to her problems, but anything that could start give you clues to what's happening. Good so far? And what do we want to do with her? What's the first thing you should do once you get your patient in there? You get all the questions you want. What's your next step? What do we want to do with her? What do we want to spend the client's money with? The first one is a inexpensive, officially costs zero, but the most information you can get as a good vet. Yep.
Heart rate, respiration, and temperature.
So a TPR, temperature, heart rate, respiratory rate. TPR will be the very basic. Can you go a little bit deeper instead of just a TPR? A weight. Yep. A whole physical exam. Exactly. On your physical exam, you're going to check face, ears, eyes, see if there is any discharge anywhere else in the body, maybe nasal discharge accompanying to that vaginal discharge. But physical exams are non-expensive. There's just your time in there with the dog. And we have you guys trained to do physical exams in 10 minutes. And a lot of information can be gained from that physical exam. Because she has vaginal discharge, we're thinking urinary, we're also thinking reproductive system. Those two things could start being palpated through your physical exam. With a good abdominal palpation, you can palpate left kidney for sure, potentially palpate the caudal pole of the right kidney, definitely palpate a bladder if she has any stones in her bladder. That's something you can find in your physical exam. Potentially distended abdomen if the uterus is enlarged, if there is a pregnancy in case, you could potentially palpate those little pregnancy nodules. So definitely always your answer is, what do you want to do next? Answer a physical exam. You're never going to be wrong. Most of the time we hear, oh, we want to do x-rays, we're going to do ultrasound, we're going to do blood work. Everything has a cost. And once you get more findings with your physical, yes, then you can move on to do that costly part. But always do a good physical. You're going to get a lot of diagnoses that are going to be discarded from just a good physical exam. So we're not spending unnecessary money on this patient. So we do our physical exam on her, and yes, this is a boy. There's a part here that females don't have, but I'm here to show you this humped back. There is a undulation, a curvature to the back. This is a typical sign of a dog that have abdominal pain. So if you see a dog on that type of posture, is an abdominal pain sign. So doing your abdominal palpation is possible, but very likely not going to be very good because they're already in pain. And if you're in pain, that's what not, you don't want anybody squeezing the painful part of your body, right? But we definitely see a depressed, but alert and responsive. I don't know if you guys heard of BAR, bright, alert, responsive, or in her case is DAR because she's depressed. Overweight, Chihuahua overweight. We see that quite often, unfortunately. Her abdomen is tense and it's also distended. We have yellow-brown staining on her perineum. So the region between the vulva and anus is yellow stained, which means she's been looking at it because discharge will tend to be just in the vulva part. And then we see that the discharge that we talked about, this is something we could ask the owners, what kind of discharge? Is it stinky? Is it normal smell? Is it bloody? Is it pus? Something that you're going to see in your physical exam. Ideally, with a glove, you'd be able to move with the vulva and kind of figure out what kind of discharge you're getting in that vulva to see what it is. So mucopurulent means it has mucus, but it also has some tint of milkiness or potentially even greenish or brownish, which is the purulent part. It's pus, it's bacteria filled. So we go ahead and order a CBC to see how good she is if she needs potential surgery. And we find out that she has a mild anemia. She's got a neutrophilic leukocytosis with the left shift. We then start fluids because we found out that she was dehydrated, and we start IV antibiotics. What is mild anemia? What's anemia? Is that a term you guys familiar with? What do we mean by that? A low count of, yep, red blood cells, perfect. So you can see anemia by just doing a PCV, which is getting a tiny blood sample, put it in a microcentrifuge tube. It looks like a capillary, it looks like a little hair. Put it on a centrifuge. Most clinics have that. This is, again, super low cost. But what you do is you pack the cells and you separate what is serum versus what's cell. And you get a percentage out of this entire blood sample, which is 0.3 mLs. You can see how much percent is actually red blood cells and what else is serum or plasma. And because she's anemic, you're thinking either she's not producing enough red blood cells, she's losing red blood cells somewhere, potentially through that discharge, or she is destroying her red blood cells. So we have to think of potential differential diagnosis that will be not producing, destroying, or losing blood somewhere. This starts in your brain, all the things that you want to think about. In addition to a discharge, she's anemic. So there's blood involved somewhere. What's a leukocytosis? Have you guys heard that term before? Something to do with what kind of cells? White blood cells. And leukocytes are all kinds of white blood cells. They have their specifics. You have lymphocytes, you have neutrophils, you have monocytes, eosinophils, all different types of white blood cells. When they're all combined together, they're called leukocytes. And leukocytosis is an increase in white blood cells. That tells you it's an inflammatory process. The most common thing we hear, very common, is, oh, it's infection. No, it's not. It's inflammation. We could have inflammation with bacteria, then we call it infection. We can have inflammation with no bacteria, then it's just inflammation. If you burn your skin on the sun and you have a very red skin for next day, you're going to have a leukocytosis from that. It's inflammatory process from being exposed to the sun, and your dermatocytes are unhappy with all this burn. So yes, it's a leukocytosis without an infection. Very possible, very likely, until you see a change in neutrophils, which is our bacteria marker for infection. We can't really tell if we're talking about inflammation only or inflammation with an infection. In her case, she has neutrophilic, which is increase in the neutrophils that are associated with bacteria. So yes, we're thinking there is a bacteria infection going on. Anybody have an idea of a left shift? Something you're going to learn, but as you're drawing anything, like if you go from the egg to the chick to a chicken, we usually start on the left and you keep going with the more mature things towards the right. A neutrophil, when you're learning about the cells, the very first cell, it's less defined nucleus, and then the nucleus got a little bit more defined, and then it gets a really characteristic nucleus. So a mature cell stays on the right side of your learning, your book diagram, and the ones on the left are the baby neutrophils that are being released. And if they're not mature yet, we call them a left shift. So it's something that's being produced by the body. It has recently happened. And before your body's keeping them until they're mature to then free them up in the blood circulation, a left shift is showing that brand new cells are being produced and we're no longer waiting for them to mature. We're just freeing them up in the circulation so they can act onto that bacteria. So when you see a left shift, it just means it's an acute process that has been perceived by the body and the body is reacting to it. Having a left shift just means you have immature neutrophils in your blood analysis. Good so far? Has anybody ever heard of left shift before? All right, that's something that's going to come on, but it's going to come to you pretty common. And that's the main reason we start IV antibiotics, is because we have a proof of an infection and we have those little new baby neutrophils that are out there. So we're fighting that infection. She's trying to fight. She's showing signs that she's actually trying to fight. So antibiotics will help with that. This is her radiograph. With the lighting here, it's going to be hard to see things, but potentially, can you see a circle here? This is a urinary bladder. Her bladder's pretty full. Then this is the canal where feces, and in this case, she has some gas for the rectum. And once it's outside the pelvic cavity, so out of the bone, we're looking at colon. And this is her colon all the way. There is a connection between the stomach and the colon. So this is all large intestines with some feces and some gas. Normal. Every x-ray is going to have that. Maybe you can appreciate a little egg-shaped structure right here. That's the right kidney. It's a little more cranial. And then another one right there. That's the left kidney, a little more caudal. And then we have kind of like a bunch of intestines here. They're not very well defined. So when we don't see loops of intestines very well defined, we start thinking of free fluid in that cavity, because fluid will have some opacity. fat is nice and dark. Fluid is going to be a little more towards the gray. So not being able to see her intestines very well started telling us we might have some fluid in that cavity. We can see the diaphragm really well. This is lungs right here. The back end, the apex of the heart is there. And then all of this is filled up by liver. So this is the edge of her liver. Liver looks normal. Both kidneys look normal. The urinary bladder looks full and normal. Everything within the colon looks normal. What we don't like is the jejunum or small intestines that are kind of fuzzy in there, not very clearly defined. Anytime you take an x-ray, we're going through from one side to the other. So there is a right lateral or a left lateral, but we're seeing all the way through. So I see both kidneys overimposed. I can't tell which one is right or left except for anatomy knowledge. Left side, ovary is more caudal, the kidney is more caudal. So I know the kidney that's more caudal here, more towards the back, is going to be the left kidney. But they're superimposed. So any x-ray, if you want to figure out where things are, you use this view, which is a lateral view, to figure out what's dorsal and what's ventral. But you can't really tell what's on the right, what's on the left. Then you're going to do what's called an orthogonal view, which is going to be a ventral dorsal or a dorsal ventral view. That's going to tell you what's right and what's left. And by the two views together, you can tell right or left, cranial or caudal, very ventral or very dorsal. Without two views, you can't really tell that. So very typical, you got two views of a radiograph. Would people take shortcuts? Yes, all the time, because you're saving money for your clients. But if you want to be the best you can be, you're always going to take those two views. So from a ventral dorsal view, we can see her pelvis down here. We can still see that gas in her colon. We can see this is more gas in the colon next to her stomach, diaphragm up here with liver. And then there's a bunch of blobs that are super weird. No organs look like this. And it does look like this blob ends right there, but really is this gas that's making the wall of this. So this blob that we see, the edge, goes even farther in. Very confusing radiograph, nothing very clear in there. Definitely distended abdomen. Can you appreciate how round her abdomen is? And we cannot see a good urinary bladder in this view either. So she goes to ultrasound. And was it needed? Not really. We don't need to do both, radiographs and ultrasound. If the place where you're working with have an ultrasound on the floor and we're not going to charge for ultrasound, why not just do it? It's quick and easy, and it's not going to destroy your machine unless you drop that probe. An ultrasound probe is somewhere between $5,000 to $10,000, just the probe, ignoring the machine part. So if they're not letting you touch their ultrasound, it's because they want you to not spend $5,000 on dropping that. This is made of crystals and it cannot take a fall. So a lot of vets will take an ultrasound probe, put it around their neck, and then ultrasound whatever they need and let go of the probe and keep doing whatever they're doing. Even this level of letting go of the probe and typing what you need, this probe could still bang in size, and we teach you to not. Every time you're using a probe, you put it on the patient. Can you use your neck? You can if you want. It doesn't really matter, but you're done. Put it right back in the machine. Don't risk breaking a $5,000 piece of equipment for a little distraction. What if the dog starts to jump out of the table? You're going to save the dog. You're not going to care about the probe. So that probe might hit something. Just put it back in the machine. And here we're looking at a view where we're going from her head will be towards this side. Her tail will be towards this side. And there's a tubular structure. And then there's a label right here for uterus. This view is going from where her right side is towards here. Her left side is towards there. So we see two tubes that are going from caudal towards cranial. So she has very enlarged tube filled structures. It's more fluidy than anything else. We can see soft tissue density on the wider part and more like fluid density inside the tubes. Good so far? So from our radiographs and ultrasound findings, we find multiple tubular structures in the caudal ventral abdomen. Structures are distended with fluid. You guys appreciated that so far, right? And they talk about moderate uteromegaly. Megaly, the word for big. uterus for her uterus. And mild peritoneal effusion and inflammation, this is where we're trying to look at her jejunum, her more small intestines, and they're kind of not very defined. There's some free fluid in the cavity, and that free fluid is called effusion. We can say effusion in the knees, when the knee is swollen. We can say effusion in the abdominal cavity. It's just a word for free fluid in a cavity that should not have too much free fluid. A little bit of fluid in every cavity, normal. Too much fluid, you can't see what's happening. There's distension, not normal. No, we call it effusion. Good so far? So her diagnosis is officially pyometra. Who has heard of pyometra before? Many of us, right? It's very common for dogs that are not spayed, and it's accumulation of purulent material within the uterus itself. It happens more in older dogs than younger dogs, and it's very common to start onset between 4 weeks and 8 weeks after the heat cycle. So your question about was she in heat, when was that? If it's happening within a month or 2 months from today's visit, it's very likely already inducing you to think pyometra. And why do we really care? There is a preparation of the uterus. The mucosa of that uterus is preparing itself for a placenta to insert in there. So it's getting all kinds of cysts and blood supply to it. So we can have puppies that are going to grow in there. And if there is no breeding, no puppies, no placenta, all this extra cystic hyperplasia in the uterus become a petri dish for bacteria culture. Bacteria enters if the cervix is open, and every time they go in cycle, their cervix will open. So that bacteria will then find a party. They can actually find all kinds of liquid, fluid, food, and they just take advantage of that cavity and they fill up the uterus with pus. And if it stays in the uterus, that's great. That's what is called a closed pyometra. Is it really great though? Because there's nowhere for that to go. The uterus is going to start contracting normal, and this pus could potentially start escaping. There's a little tiny opening where the ovaries meet with the uterus, and now you're going to start leaking pus into the abdominal cavity, which causes peritonitis, infection of the peritoneal or abdominal cavity. 80% of animals with peritonitis will die. We can only save about 20% of them. So a closed pyometra, the owner doesn't know what's going on. There is nothing leaking out of the vagina. It's very fast. Within 3 to 4 days, that animal could die. They will stop eating, they'll start puking. And if the client wait till Monday, this happened on Thursday, by Monday, when they get a vet to see a dog, they might not have anything to do anymore, because closed pyometras will produce all this bacteria, all the pus stay in the uterus, nowhere to go, very fast endotoxemia. Whereas a open cervix is the best it can happen, because they will start leaking this nasty thing. It's usually pretty stinky. The owners can tell that the animal is uncomfortable. They're looking at their fluid, they're having the excretion in there. They are also able to take some of that pus out of their uterus. So the uterus is not going to get so engorged so fast. They're actually getting rid of the pus a little bit. So a closed pyometra is a lot more dangerous than an open pyometra. An open pyometra is easier to diagnose from a client perspective. They realize something is bad and the smell really bothers them. They tend to bring the dog into a clinic a little bit faster, and you have more time to work those up before they actually don't make it. Are we good so far? So there are treatment options for pyometra. Some of you guys have met my husband. He is all in pro of reproduction, and I'm the other way around. I take the uterus out. I take the testicles out. I'm like, we don't need more dogs. We just need pets. We don't need to overpopulate our globe with dogs. But if it's a very expensive animal that you still want to breed, you still want to get puppies out of it, maybe it's a champion from a dog show of some sort, you could treat pyometra. Pyometra can be treated with medical therapy. You would do antibiotics for sure. So independent of anything, surgery or medical treatment, antibiotics will get in. And then you do prostaglandin, which is a hormone that's going to help squeeze the uterus. You can only do that with an open cervix. If you start doing prostaglandin and the uterus start contracting, you're going to burst the uterus. The uterus is going to rupture. And now you're going to create a peritonitis induced by the vat. And the other choices, what my choice is, let's just get rid of that uterus. She's not using it. Why do we need to have the hormones messing up with everything? So going to surgery is what happened to her. Have any of you guys taken anatomy before? A little bit? So when you take anatomy, you learn a bunch of things. It's almost like you're learning a language. Seems like nothing is going to make sense for you in the future. Like, why do I need to know this? This is a perfect example. And here we're looking at ovaries. There's two horns for the uterus. There are two uterine tubes that are actually transporting the oocytes towards the uterus. There is a body of the uterus. There is then a cervix. Below the cervix will be the vagina, all the way to the opening of the urethra where urine come out. Then there is a vestibule all the way to the beginning of the parts where you can see on the external exam. And then the very last part is the vulva. So when we're doing SPAY, the only pieces that we mess with are anything that are above the cervix, so the body of the uterus. We remove that body of the uterus. We also remove both horns, the right horn, the left horn. We also remove the both ovaries. Ovaries are your main enemy. They are the ones that are producing all the hormones to mess up with the uterus and allowing for a pyometra. If we had no ovaries, they could still have a uterus and they would not have a pyometra. Something that's already happening in most European countries, that they're doing just a ovariectomy, leave the uterus alone. American culture is not there yet, but who knows, 5 years from now, 10 years from now, when you're graduating, when you're still working, you're probably going to move on from what we do currently, which is ovarian hysterectomy, ovary and uterus. We're going to move on to just an ovariectomy, just ovaries. We're not there yet. Culturally, haven't moved forward, but we will. There's no way around it. Other things in anatomy that seems to be super annoying is all the ligaments and all the names of other parts of the body. Again, extremely important. This is a closer view of an ovary. The ovary is stuck to the ribs, both sides. And when you try to get in there in surgery, they don't come to you because they're stuck all the way deep in there. So there's something called a suspensory ligament that you can go with your finger and you can actually break that. Like you're playing a guitar, you can strum the suspensory ligament and break it away from the rib. So an ovary that you're trying to see and you can't, once you break suspensory, boom, you have a great view of it. And now you can do surgery on something you can see versus doing surgery on something that's hiding all the way inside. So understanding suspensory ligament, huge important step for your success in surgery. There's also something else called a proper ligament. It's a bunch of collagen fibers, very well organized, strong collagen that connects the ovary, which is this round circular thing, to the end of the horn of the uterus. This guy, this proper ligament, is so good that you can clamp and you can put force in there and it won't break. If you don't know what the proper ligament is and you accidentally put your forceps or your clamp in the ovary, it's taking a piece of cake and putting a clamp right through it. The cake's going to fall apart. You want to take the wrappers that actually can handle the strength. So your suspensory is collagen, your proper is collagen. So understanding the anatomy of things where you can clamp and put force will make you a successful surgeon versus clamping the wrong thing, put force in the wrong thing, everything falls apart. Now you have a clamp in your hand and a hemorrhage in the cavity. So going back to anatomy days, really understanding your anatomy makes you a fantastic surgeon. All that you're doing in surgery is you're correcting anatomy to go back to where it should have been in the first place. So anytime that you're learning new things in anatomy and you're pulling your hair out and you're like, why do I need to know? Why don't you just ask somebody like, why do I care about this? And I guarantee you somebody there will say, well, this is going to come important when you're doing your space or whatever else. Like if you're doing nucleation, you need to know all the muscles around the eye. If you're doing a nasoplasty, you need to know all the cartilages around the nose. So anything that you do in anatomy comes back to you all the way for the rest of your life as a vet. So she goes into surgery. We place her on the table. It's called dorsal recumbency, where her dorsum is on the table, her abdomen is exposed. And then we do something called the ventral midline approach, where the very center of the animal is going to be where we approach. In humans, C-sections are happening transversally in the abdomen. In animals, we go in the same direction as the linea alba, which is the center of the dog. That linea alba doesn't have vascular supply, doesn't have innervation. So it's really good to hold your sutures back together, very strong. It doesn't hurt very much. It doesn't bleed on you. A lot cleaner procedure. And in a human, it's not a beautiful scar. So they don't do many ventral midlines unless we're doing heart surgery. Most abdominal procedures, they try to hide a cut and they will be a lot more painful. What we go for is minimizing pain. We don't really care what it looks like. There's going to be a bunch of fur that's going to cover it anyways. We're just going for the cleaner, most efficient approach. I do have a few slides that are pictures, but they're not as fun as the videos. Sorry, this cable is not very happy. So this is a midline of the dog. You really have to palpate the umbilical scar. It's very easy to lose the center. We enter the abdomen in there. What we're looking for is we have cauda vena cava, aorta. We have two kidneys. And like we're saying, left kidney is a little more caudal, right kidney a little more cranial. Same thing for the ovaries. Left ovary, a little bit easier, a little more caudal, easier for you to see. Right ovary, a little more cranial. So that's what we're looking for. We're looking for the organs that are immediately caudal to the kidneys. They have vasculature going towards the aorta, but they also have a vasculature going all the way down towards the cervix. So we have two sources of blood supply, the ovarian source and then the uterine source. So when we're doing surgery, we need to get rid of the vascular supply because that's what's going to cause hemorrhage. This is going to show in the video too. I'm just going to go straight down to it. We were talking about the end of the horn and the beginning of something called the proper ligament. This is a great place for clamps because it's very strong. And then there's an ovary. So if you clamp in the wrong place, you clamp in the ovary, that's going to tear. If you clamp in the horn, that's going to tear. If you have the clamp right there in that transition between these two organs, your clamp's going to hold well and you don't cause hemorrhage. If it tears, these vessels that are representing here are the vessels that are going to bleed on you. How long will it take? Somewhere between 20 and 40 minutes from the tear, that animal's going to die. So you do have time. 20 minutes is plenty of time, but you don't want to be looking for your hemorrhage for a whole 20 minutes because that's going to make you stop breathing for 20 minutes. This is what looks in real life where there is an ovary here. There is a proper ligament there. There's the end of the horn right there. So this is what surgeons are looking for when you're doing a spay. Clamp placement, I'm going to go through it in the video. It's a lot more fun. Let's go in there. So first, approaching the cavity. The lengths are not going to work. Can I switch to my computer?
Yeah.
Go in with my dominant hand and I'm going